Hi again, everyone. I'm Brian Lewis with KidneyCAN, and it's my pleasure to welcome you back to another joint edition of the National Kidney Foundation's Facebook Live series. Today, we'll be discussing the topic of kidney cancer and some of the treatment options that are available. My guests today include Dr. Gennady Brotslawski. Dr. Brotslawski is professor and chair of the Department of Urology at SUNY Upstate Medical University in Syracuse. In full disclosure, Dr. Brotslawski has been my surgeon and was an instrumental force in me being here today, but we can possibly discuss that later in the program. Thank you for being here today, Dr. Brotslawski.
Thank you for having me, Brian.
I'm also happy to be joined by Dr. Adam Stern. By trade, Adam is a practicing psychiatrist, but today he joins us as a kidney cancer patient who can share his experience in dealing with kidney cancer. Thank you, Adam, for joining us as well.
It's my pleasure to be here.
Great, great. Well, I'm going to get started by jumping into some questions for us right away. So I'm going to start with you, Dr. Brotslawski. I remember that day vividly when we were finished with the waiting room, called back into the patient room, and the door gets shut, and you're supposed to wait for the doctor. What's going on out there with all of you doctors as we wait for you patiently in the room?
At that time, we usually look through a large pile of films and papers and review records and laboratories, and trying to formulate the best treatment plan and the options that you will be presented with, or any patient will be presented with.
Right.
This is not something that is prescribed. It is something that is individual. And by that time, we must review and put many things together before walking.
Got it, got it. So on that topic, Adam, you were first diagnosed. Tell me about your experience when it first happened, and what was going through your mind?
Absolutely. When most kidney cancer patients are diagnosed, or cancer patients in general, they have an immediate rush to feeling overwhelmed, feeling stressed, just wanting to be done with the cancer, wanting it removed and to put it behind them. So one thing I'd like to stress here is that it's so important that newly diagnosed patients are actually able to find treaters that are experts in the field that treat this condition all the time. And that may actually take a little bit of time in order to be set up with someone like Dr. Brotslawski, for example. And so one thing to keep in mind is that although you may have just been diagnosed in a single day, the cancer has likely been with you for a long time, and it may pay off to take the extra time to get set up with a team that really works well in kidney cancer.
Got it, got it. So you're a surgeon, Dr. Brotslawski. The first diagnosis many times involves surgery. Can you tell us a little bit about nephrectomies and the world of partial nephrectomies and radical nephrectomies?
Of course, not every patient needs a surgery. Not every surgery is the same. And perhaps the best statement would be, in many cases, if we can avoid doing an unnecessary procedure, we're probably doing most service. Nevertheless, the surgeries are different when they're required. When the disease is localized, the treatment options certainly would include keeping the tumor in the kidney and just proceeding with some known as an active surveillance, because not every patient needs that tumor removed. Sometimes we may be able to remove only a tumor with a tiny portion of the kidney, and sometimes we must remove the entire kidney. And there are many approaches and there are many risks, but in more advanced diseases, then it becomes more of a challenging discussion in terms of what treatment options are right.
So you bring up some new language or new terminology that we all have to get accustomed to. You said localized. Localized as opposed to?
As opposed to localized, meaning it's within the kidney, as opposed to be metastatic or widely spread when the tumor went outside the kidney.
And so when it's localized, you're trying to save or spare the kidney as much as possible when you operate.
In appropriate patient, when the tumor is in appropriate of appropriate size and in appropriate or safe location, that is doable, and we want to cause no harm in trying to spare the kidney. And of course, we try to spare kidneys as much as we can, but again, this is taken always this is always given a very careful consideration.
Got it, got it. So Adam, tell us a little bit more about your treatment options. When you were first diagnosed and you're hit with all of this information, first of all, did you have someone with you or some others to be involved with the decision-making process and all the information you were gathering?
Absolutely. I was very fortunate because I'm within the medical profession in a large institution that I actually had excellent access to care, and that's something I wish for all patients. And so I had the unusual benefit of both being in touch with a urologist that would potentially perform the surgery, as well as a medical oncologist, both of whom are specialists and experts in the field. It was only a week before I had my nephrectomy scheduled and performed, and a number of options were discussed with me after that, including what we eventually ended up doing, which was immunotherapy. That's a kind of treatment where you're trying to rev up the immune system to go after any remaining cancer cells.
Right. So we're going back to this idea of being in the patient room, waiting there for the diagnosis and the information that's being shared. We talked about this on the last segment, where we have caregivers that are part of this process to help with the decision-making process. So talking about shared decision-making, what went into that process for you? Did you have a team around you? Did you have just one surgeon? Tell me a little bit about that.
I think in most cases, excellent medical care these days is a team-based approach, and the patient is at the center of that team. So patient-centered decision-making and shared decision-making, to me, they both mean that patients are making decisions with all of the information available to them as provided by their physicians, recommendations that are being made by people who are experts and know what they're recommending. And so as part of that team as well, the patient ideally has caretakers, family members, people that they can rely on to be sounding boards if they're not sure which way to go with a decision. And ultimately, it comes down to your trust and your relationship with your doctors and your medical team to decide which way to go forward.
So tell us, Dr. Brotzelewski, with your residents and your younger physicians, how do you, incorporate shared decision-making in their training so that they know that that's a part of what they should be doing?
You asked me what happens first when the patient's in the room and what happens outside the room. Well, first you ask the residents, what should you do? What should we do? And then, what should we do, or what my residents think we should do, or what I may think we should do, may be very different from what the patient chooses to do or the patient's family. So I always attempt to bring resident with me into a final discussion, because I truly think that the final and the best decision is made with the patient when the patient is presented all the options. And as crazy as some of the options may seem, because they usually are on a spectrum from doing nothing to being a little bit more and much more and very, very aggressive. Some may only take the road part way. Some may say, I would much rather die fighting. And some may say, I would like to enjoy this quality of life or whatever is left. Or whatever I may just get, because I still am not sure if adding this and this and this further down would affect how long I would live. So in this case, I think it's important in training to bring these trainees into a room and to allow these patients ask questions, to hear their thought processes, to give them an opportunity to think, to give them an opportunity to think with the family or even to return with the family.
Do you encourage patients to take notes or have someone there to take notes with? I just remember we talked about this before. There was a sense of white noise at times, which is my term for just being inundated with new language, new terminology, new stressors. So do you have situations where you bring people in?
I always ask, especially on more challenging, but even on not very challenging, quote-unquote, surgical cases, I often advise that the family of the patient comes in. I ask them about their support. I ask them who is going to be taking care of them after surgery, and I ask them who is going to help them make the decision. I often find that patients now in the digital age have their family member on a speakerphone. I often find that they have me recorded prior to us starting the conversation. Some announce that they will record me, and some just announce me after the interview. But most importantly, it is indeed crucial that they get as much of the information. I cannot tell them you must take notes, because I draw pictures, I give them pamphlets, so I would like them to learn in the best way possible. But I agree with you that having them informed in whatever way, shape, or form they take it, I think is most important.
Okay. And Adam, on that note, just hearing Dr. Brotslawski talk about it brings up a little bit of anxiety in me, remembering those days sitting there waiting for treatment option decisions. Tell us a little bit about your situation. When you were there, you had your wife with you, you had other family there, and were thinking through and discussing the options?
Yeah, at the initial diagnosis, well, because I'm a physician, I made a mistake, I would say, and I actually got the images of the disc from the scan that I had and brought it over to my own hospital and radiology, and I couldn't find a radiologist, so I put it in myself. And actually, staring back at me was this very obvious 10-centimeter mass on my kidney. While I was doing that, I was speaking with my brother on the phone, who was a physician as well. And so I had support there, and then by the end of that conversation with my brother, my primary care doctor was calling with the official results. So I should have just waited. This is a lesson that I've learned. You always should really wait until your physicians that are treating you are presenting you with information, and that's probably the best way to go forward. And it was very quickly after that that I told my wife and my parents and the rest of my family, and together we started to both grieve the loss of this innocent life that we had thought we had, and also start planning for the future and figuring out, okay, now what comes next? What are we going to do?
Great. So one of the things I picked up on there, I'm a lawyer by training, and one of the phrases we used to tell ourselves is if you represent yourself, you have a fool for a client. And so I'm wondering, when you were there, looking at your own scans, maybe, I went off to the internet looking for information, one of the biggest mistakes I ever made. So can you just comment on, telling patients out there, folks that are listening and watching, what to avoid, maybe what they could be doing that would be more beneficial for them?
Yeah, and I think that's an especially pertinent question right now, because we're in an age where more and more the medical record is being shared online with patients before even they've had a chance to necessarily meet with their doctors. And that's a good thing. Overall, that's a trend. We want to be more open with patients and vice versa. But there's some risk to that, because patients aren't necessarily trained in the language of how these reports are written or how the scans come out. And so I think that it's a very useful thing when patients have access to their medical reports and equal access to their physicians who are able to assist them and guide them through reading and understanding those reports.
Got it. So Dr. Brotslawski, do you all have any kind of navigator system or any kind of internal system in your hospital to help the patients between you and their decision making?
Of course. So we have, most cancer centers have the cancer navigators, and they could be either department specific, disease specific. We have some in genitourinary oncology. We of course have numerous navigators in the Upstate Cancer Center. And the goal of these navigators, the roles of them are quite numerous. Anything to navigate from one appointment to another, as to having an access to of a cancer patient to a healthcare provider at all times, to deal with anxiety, to deal with anything from scheduling to nutrition to support. So these are enormously important roles. And yet, I'd like to second Adam's concern that as we also become more transparent with some of these records, sometimes these KidneyCAN navigators almost become victims of our transparency or transparency of medical records, of our healthcare systems, and those quality metrics where patients should have an access to their charts almost immediately. And sometimes these interpretations of radiology reports and just pretty simple jargon that to us would be overlooked as, that's nothing, is extremely anxiety provoking. So these navigators also act in the role of support, psychological support, social support. These are enormously important positions.
Got it. And I want to just go on to that a little bit further. So with preparing yourself, so post-treatment options are given to you, you've had the shared decision making, you're starting to prepare. Anything in specific you can point to that helped you in that process?
I think the best advice that I would give to patients in that situation is to try to recapitulate their aspects, as many aspects as they can of their normal life, to especially fill their lives with things they find fulfilling. Their lives will never be the same after a diagnosis like this, but that doesn't mean that everything it has to be vacuumed out and only cancer can exist. In fact, people live very full, rich lives with stage 4 advanced disease, and for many, 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 many years. And so that's my number one piece of advice. almost in an inverse way, I also want to advise people that it's okay to allow themselves to have complex emotions around the diagnosis, to feel the trauma of the diagnosis in any form that it takes. So that might look a lot like depression or anxiety when it comes out. And that's okay, because that is one of the ways that we adjust to something that's really altered our way of life.
So let's touch on that for those out there. We have some resources that we can turn to in addition, as opposed to just going out searching on the internet, and that includes the American Cancer Society, the KidneyCAN's web page, the National Kidney Foundation's web page. I'm sure your hospital has kidney cancer information and other information. There's another resource called Smart Patients that we all participate in that allows for a conversation amongst others. Are there any other resources that you all point people to that I'm overlooking?
Adam?
Well, I want to answer you in a somewhat more generally and just sort of say that it's extraordinarily important to feel as though you're part of a community that understands what you're going through. And for me, I find that at Smart Patients. I find that in the various organizations that you've listed, and being able to contribute in some way by participating in an endeavor like this that we're doing right now, or any way that I can, has been very helpful for my own mental health. But I think you hit the big ones that I would think of.
Okay.
Well, we also have to remember there are excellent kidney cancer support groups, as you know, run by Dana Beadle, and also is also the organization run by you. So I think be able to connect to these patient support groups, to be able to connect, and luckily due to the social media that I'm not a big user of, but there is an enormous access to other patients, to other patients' stories. To share, to cry to each other, and this allows one to cope with the disease so much better, to know that there are success stories, many success stories, survivor stories. Okay. And sitting next to Adam and you makes me, humbled in some of the other blessings that I have without not having to have dealt with such diagnosis.
Sure. Great.
But having your guys' expertise and access to other patients, I think, is probably the biggest resource out there, other than, our professional societies.
Brian, I'd like to add just one extra point to that, which is that, I would say the majority of patients will adjust to their diagnosis and find some semblance of normalcy right alongside this change that's happened in their lives. When it doesn't happen, when someone is really struggling, where they can't find quality of life, where they can't achieve the things they want to achieve because of the stress that the diagnosis or treatment may be having, seeking out mental health treatment from within their team, within their institution, recommended by their doctors, it's tremendously stigmatized, but it's actually potentially very helpful for a lot of people.
Yeah, so I think the takeaway for everybody here is connect with someone, some way, no matter what your personality is. It'll be helpful.
You're not alone.
You're not alone. Okay. Well, I'm going to shift gears here a little bit and talk a little bit about clinical trials. So can you tell me a little bit about your experience with clinical trials? I know you were at the NIH, where that's pretty much what you all were doing. I know it's an underrepresented area of kidney cancer. I know that getting participation is always a struggle. There's a variety of reasons. Any comments on telling folks out there about the clinical trials that are out there?
So luckily, the number of kidney cancer clinical trials is enormous. And this may be either sponsored by the NIH, NCI, or cooperative groups. These are some that are sponsored by pharma, some that are run by numerous professional societies, including the Society of Urologic Oncology Clinical Trial Consortium that consists of over 200 academic sites that part of the consortium to promote. And in fact, one of the two largest clinical trials have been accrued by the urologists and medical oncologists dealing with kidney cancer. It's extremely important that each patient at least inquires about an opportunity or a possibility of a clinical cancer, of a clinical trial for kidney cancer. It's also as equally important that physicians treating kidney cancer look and think, is there a trial that may potentially help this very patient? It is a two-way street. We should not just be technicians, a surgical subspecialty. We should not just be looking for a way to complete a procedure and send the patient away. We often are the gatekeepers as urologic surgeons, but we have outstanding medical oncology colleagues that we can work well with together to encourage, again, participation. And clinical trials often offer the standard of therapy plus something else to see if there's addition of something else or comparing a standard to something else, at least in kind of a later phases.
Right. Yeah, I know that we were talking about this a little bit before. There's this perception or concern amongst patients that they're going to be placed on the placebo arm of the trial, and that discourages them from participating. You were saying earlier today, Adam, that you know what, you can always exit. Mm-hmm. Do you want to just elaborate on that a little bit?
Absolutely, yeah. And I want to preface my statement by saying that clinical trials are where the most cutting-edge treatments currently exist. I think that an opportunity to participate actually potentially gets you access to newer treatments that if you wait until they reach the clinic may be years from now before they're available. But to your specific question about exiting trials, active treatments versus placebo treatments, the first thing to know is that if you're participating in a clinical trial, you can always stop at any time, and there are no repercussions to your clinical care. And second of all, I'd like to say that generally, clinical trials are juxtaposed of standard of care against a new and potentially better treatment. The only times that you might use placebo if there is no standard of care, and so then you would try a new treatment versus placebo.
Great, great. Well, I'm going to have to cut us off here for a second. As we did last time, let's take a look at some of the questions that folks watching on Facebook have been asking. And I'll remind you that if you have any questions on this subject, please post them in the comments section, and we'll do our best to answer as many as we can. If we run out of time, please know that all your questions will be addressed on the National Kidney Foundation and KidneyCAN.org's Facebook pages after the program. Well, here's our first question from our audience. Looks like this is a question for you, Adam. Where did you turn after your diagnosis specifically?
That's a great question. You know, as I mentioned earlier, the very first emotion I was feeling was, get this cancer out of me, essentially. And so my primary care doctor hooked me up with a urology office that he tends to work with. And it wasn't until several hours later that it occurred to me that the very first option that's available to me may not be the best option for me. And so through my connections through our institution, I was given the information for a team and hooked up with a team that works only in kidney cancer. This is what they do, and that's again something I want to reiterate that's important for everybody to find a treatment team that knows what they're doing and that this is their passion, this is their area of expertise.
Great, great. Looks like we also have another question for you, Dr. Bratslavsky. Surgery is the leading option for many patients. Do you recommend to the patient perspective of get this disease out of my body? Or we also heard there are some other therapeutic options.
Yeah, as much as I'm a surgeon, I would like to spend my day in the operating room. I must admit that kidney cancer is a disease of different, what is known as stages. For some earlier, or what I mentioned earlier, localized stages, then perhaps removing this kidney or removing the tumor or the entire kidney may be indeed the best option. For patients when a disease has advanced so much further that it has spread to other organs, removal of this kidney may not actually improve how long the patient will live, how well the patient will do, and it may not truly be the best option for this patient. Where systemic therapy or drugs could be the first step, it does not mean that the tumor later may not have to be removed. It does not mean that the surgeon will not get a chance to operate. But if we look at what the literature shows, we have learned one thing, that not every patient that has kidney tumor needs to be operated on. Not every patient that has kidney tumor either within the kidney or spread must be operated on. And for this reason, it should really look for expertise of those who treat kidney cancer, and especially expertise of teams that deal with kidney cancer.
I know, just on a personal note, I know when I was diagnosed, there was IL-2, there was a new drug, Sutent at the time, and surgery. Those were the options really, or nothing. Now there's what, 15? 15?
There are many, and you can count as number of drugs because there are now new combinations coming along.
So there's more.
So
more
there
out
are
there.
many drugs with many combinations.
And back to my white noise term, only having 3 or 4 options a while ago, now having 14 or 15 in combinations, you got to turn to some experts for help in deciphering all of this information. Okay, so I'm going to ask you a technical question. I didn't know this word for the longest time. What does adjuvant mean?
Adjuvant is in the way it's used in medical jargon. It's an additional therapy given for patients when we have no measurable disease. So when somebody has the kidney removed, let's say, and they have no signs of disease anywhere else, but we know that on a level of a single cell, there are maybe few that have parked somewhere else. We just can't see them. Then we say, why wouldn't we give an adjuvant therapy, additional therapy, to help and catch and kill those cells that are trying to park or survive somewhere else? So therapy given to a patient after the main treatment was completed, usually surgical treatment or radiation treatment is completed, then the adjuvant therapy given. And again, the adjuvant could be radiation, adjuvant could be drugs.
Okay. And in addition to adjuvant therapy, there's targeted therapy, systemic therapy, and immunotherapy. So there's a lot of therapies out there. Again, another example of this new language that patients need to learn and have navigators or their physicians help them with in the shared decision-making process. Great. Okay, so it looks like we have another question here for Adam. Adam, how did you handle treatment from a psychological standpoint, and what role does anxiety play for most patients as they go through this life-altering process?
Thank you. Yeah, that's an excellent question, and we've touched on it a little bit already, but I think that one of the takeaways is that it's normal to experience a variety of emotions. No one who's diagnosed with this disease will experience it in exactly the same way as anyone else. Generally, our minds tend to try to solve problems, and when you're dealt with a cancer diagnosis, there are a lot of unknown problems. How is this going to turn out? What's the treatment going to be like? What's the prognosis, etc. And so your mind is trying to answer all those problems through anxiety. It doesn't seem like a very adaptive way of doing it, but in fact, that's an evolutionary thing that we've all evolved to do. And so I would say that a certain level of anticipatory worry, of rumination is to be expected. I would say the time to really maybe potentially seek help for it is if it reaches a point where it's dominating your life, where you're unable to do the things in your life that you want to do or that you've always enjoyed doing, and that's happening more days than not. You know, we all have down days every once in a while, but if you're actually not able to function in the way that you used to be, it might be time to talk to someone.
Got it. Got it. Any comments for folks on the emotional side of things, psychological side of things that you can recommend?
Well, I find often that especially in the hospital, when the patients get through this major surgery, I can see how their energy levels sometimes just drop, and on the initial visits after surgery, their levels of fight appear to have subsided, and you can see how it finally hits patients, sometimes later in treatment, sometimes after a major surgery. And it's important that we continuously focus, even as physicians, particularly as surgeons, on the fact that many of these patients may need a lot more psychological support, psychological counseling, again, family support, asking for this support mechanism, the social network that they have, is extremely important for their well-being.
Yeah, family, friends,
Absolutely.
Their churches, synagogues, what
Absolutely.
all are part of the process.
Above. Yes.
It's important to know. And we also listed a number of those support groups, and we can put those on our website because I think that having those resources at your fingertips is crucial. So it looks like I'm getting the cutoff sign here. So is that correct? Let me know if we're running out of time. I think we are. So I'd like to remind you all that are watching that this is the second of a 3-part series on the subject, and I encourage you to join us again when we discuss how to keep the best quality of life with kidney cancer. In case we didn't get around to answering your question today, please check back on the National Kidney Foundation and KidneyCAN's Facebook pages, where we'll be posting the answers throughout the coming days. I'd like to thank our sponsors for their generous support in making this program possible. And I'd especially like to thank Dr. Brodslavsky and Dr. Stern for joining us today to help us make sense of what I know is a life-changing, psychologically and emotionally challenging subject for so many people. Thank you all very much. Really appreciate it.
Thank you.
Thank you.
Brian.
On behalf of the National Kidney Foundation and KidneyCAN, I'd like to wish you all good health.
Thank you, Brian.